So we've been talking, if you look at CGM data in general, you have two types. You have real-time data. Person can see exactly what their blood sugar is anytime they want to. And you have retrospective data. And we've been talking mostly about retrospective data. So we have a question regarding whether there's an application or website in which you can enter a patient's information to give the time and range diagram, which is to say, and this can be for Dr. McCoy, and I think Stacy's answer will probably be a little different. How are we accessing retrospective data with these devices?
Yes, I can share kind of what we're doing in our clinic. In our primary care practice, we primarily focus on patients who have intermittent scan CGM. So because that's the majority of patients who have type 2 diabetes who are managed in primary care, use IS CGM versus real-time CGM. So we did sign up for the Libre View account, which is what Freestyle Libre comes with. We set it up for our whole clinic. So when we have patients who do get the Libre, we kind of invite them to join our clinic's team so that they can upload information that we see in clinic, whether they're in the appointment or not, or they bring the device with them and we upload it during the rooming process. And then during the appointment, or when I'm taking care of them by portal or phone, I can see that information and get it easier. There's similar things you can do with the real-time CGMs. We don't use them yet in our primary care practice. We're working towards it, but it's a bit more complex, and every device has its own cord and cable and software, which makes it, I think, harder for primary care practices. So I think if you're just starting out, I would really look at your patient population and where you want to start with for the clinicians. But ideally, you'd have an educator, and I think they'll know all the nuances of what to do for all your different patients. But I think that's really critical to be able to access that information.
I'll bet you Stacy has a very sophisticated setup for accessing these cloud-based data for retrospective CGM review.
We actually have a lot of the same as Dr. McCoy was saying. We have the opportunity to use Libre View, Dexcom Clarity, CareLink for patients. We strongly encourage the patients to be able to upload their data. Now with the pandemic, that has become a little bit different. And I mean different in the fact that it's more strongly encouraged. So we're linking a lot of people to be able to share their data, with us, because in the remote world, you can't come in and drop your CGM off at the desk for someone to, upload that for you, where a lot of our patients were, I think, kind of used to that. So we do use all of those same websites and are getting people linked and connected in the right way.
Yeah, I know in my practice, we really lean on our diabetes educators for startup, essentially, because people really, it's pretty intuitive. You can go on these industry websites, you can watch videos, and you can have a CGM in place and on your telephone very easily. But I think what I've observed is that there's a huge role for diabetes education to help people understand time and range goals, help people understand what to do with the data they're seeing and how to really use it to improve safety and improve the management. But I know one barrier that a lot of practices have, I'm a little fortunate to have diabetes education right in my clinic. What do we do if somebody doesn't have access to diabetes education for startup of the device, for helping to get hooked up to these industry clouds, and for teaching?
So, I think I can start off. So we don't have, unfortunately, an educator right in our clinic. We're thankfully able to refer patients to an educator when we need to. But we've leveraged our clinical pharmacist a lot. I know many places don't have pharmacists either. I think pharmacists are fantastic because I think they're easier sometimes to get because or to justify because they serve so many needs for a variety of chronic conditions. So they can help support diabetes as well as other things. So I think pharmacists can serve that role as well. You can get a lot of really helpful, I think, information from websites. There's YouTube videos, just make sure they're reputable. I know ADA makes a lot of information as well, both for patients and for clinicians. So there's a large repository of materials that can be used as references. And we actually, to get our patients started, we have, again, like a smart phrase prepared that we send for how to patients to sign up for LibreView and get connected. And that was actually prepared by one of our patients who did it and then shared it back with us, and we are using it. So that's been fantastic because it really is an easy kind of walkthrough guide. I think it's hard the first few patients you set up because you don't have the system established. But I think even our care team nurses now are very good at using at least with the Libre, and getting our patients set up, connected. Even local pharmacists at the community pharmacy can help patients get set up. So I think there's a lot of knowledge about this. We just have to ask.
Wonderful. So here's a question. This is a practical question, a very useful mnemonic in helping to think about time and range goals is more green, less red, which is to say, if you're looking at that stacked bar graph, you want more green, you want your green to be greater than 70%, and less red, which is the hypoglycemia range. You want that less than 4%. So the question is, our printer only prints in black and white. Can you suggest anything to help highlight this concept and really help people use data in a functional way, an intuitive way?
I pull it up on the computer. We have the same thing. Our printers are all black and white. So I just pull it up in the office and show it to my patients. And I think it becomes, and then I kind of use my hand. I use my hands a lot, so that tends to also help. But yeah, I agree. The stoplight definitely helps drive it across. And then I do talk to my patients about the flat, narrow, and in range for them to be able to see it on the actual profile. Because when they see the rapid swings, I think they intrinsically understand that it's not safe to be going, roller coastering your day, and that's something we should avoid.
So here's a glycemic metrics question. What's the recommended % variability on an AGP report? And so it's an interesting question because it raises the whole topic of variability, because unlike fingerstick blood glucose monitoring, you're seeing people go up, you're seeing people go down. I mean, the target for variability is less than 36%. But what do we do when we have these folks who are all over the board? And it really is highlighted by this data. How can we help them to improve their management?
I would love to hear Stacy's thoughts on that, but I can jump in afterwards. Hear what the experts.
Yeah, I think that's a great question. And I just actually wanted to go back to the person's question about if you're printing in black and white. We do a lot of the same thing that, I pull my screen up, and if I'm in the office with the patient, I can share that, but I can even share that data on the screen with them virtually as well. So I often do that. So, because it also, I think, brings home, because you can kind of start to talk about the reports and point out the important pieces that we look at, but that they should be looking at, looking at as well. As far as the question is about helping with glycemic variability, and yeah, I mean, that I think goes back to, as an educator and as a provider, helping the patient identify trends. How often is it happening? Getting that percentage. Is it a trend? Is it something that, if it is that trend, is it something that is, that fixable? Sometimes I feel like patients may get a little more focused on we'll call them the random lows or the random highs, and they focus in on that versus the actual pattern. And I'm not sure that completely answer the question, but I kind of take it from that angle of really looking at, okay, what are we seeing here? We need to focus on, like anything, even in finger stick management, we always try to focus on the lows first. You continue to do that with CGM as well.
Yeah, And to add to that, one thing that I do is that's another reason why I really like the AGP. I know I keep coming back to it, but it also shows us, it helps us by looking at the overall, the 14-day trend, you're going to get away from those one-offs and help focus on the patterns. And, with the great variability, it often comes to, I think, three things, especially for our patients on MDI therapy, that I talk to them about. But we talk about when do they bolus, because often the rapid rise and fall, it's for patients who bolus after meals. So they go high and then they plummet. Patients who overreact to everything. So if they're high, especially postprandial, and then they overtreat that, and then they have a low, then they overtreat that, and they become into a cycle of highs and lows. So I think working on patience and the rule of 15 for treating lows, and I think being a little bit more tolerant of postprandial highs so that you don't have a low. So I think that is helpful. And then the other is seeing if it's a particular meal, what patients are eating. I have one patient who had horrible variability, always in the morning, first thing in the morning. Nothing we did seemed to work until we realized she was buying this fancy coffee drink with probably the most sugar imaginable to humanity. And as soon as we substituted that one drink, problem disappeared. So I think really knowing what your patients are doing is very important. And that's why seeing those patterns, I think, is so much more helpful than just the snapshots of blood sugar readings.
Yep, wonderful answers. No, I know when I see individuals with very high variability, I start to think about timing, obviously, as you guys have pointed out, and barriers. Is there a cost of insulin barrier? Is there something that's causing people to miss doses? And I also think about, is this a perfect candidate for a diabetes education consult? Because I can tell you our diabetes educators are expert at working through troubleshooting.
Mm-hmm.
So here's one. What is your approach? And I think either of you can take this on. What is your approach for adjusting time and range targets in older patients and those with higher risk of hypoglycemia, perhaps higher risk of hypoglycemia than hyperglycemia? How do we adjust our targets for modified goals?
So I know for the intermittent scan CGM, it's kind of embedded. So I think the pictures is what you get. Practically speaking, I do have a higher lower threshold for my patients who are at risk for hypoglycemia, as well as patients who have different glycemic targets because of limited life expectancy or complexity of regimen. So you kind of go up even 100 to 180 or even 120 to 180, depending on where they are. I think the biggest thing to realize is that we're not adjusting targets because we are ourselves unable to modify their regimens well enough and we're just giving up. So I think you still have to make sure that we're trying to get our patients to be in a safe range rather than just modifying the targets, because you do have, if they're having hypoglycemia, changing the target alone won't solve the problem, right? You have to change their regimen. But I do think it's important for our patients, especially with an impaired awareness of hypoglycemia or frequent hypoglycemia, to at least strive to be closer to that 100, above 100. I don't know what Stacy, what are your thoughts are?
Yeah, I tend to, I think for those patients that have hypoglycemia unawareness, just trying to set that threshold on that alert or that alarm is helpful, usually around 90, so that they can catch, so that they can catch it earlier.
And I guess I'd point out it's helpful to keep in mind that these international consensus goals from 2019 actually include some modified targets for individuals who are at higher risk for hypoglycemia, who have limited life expectancy. And so for that group, the time and range target goal would be not greater than 70%, but greater than 50%. And for those folks who are at higher risk for hypoglycemia, the hypoglycemia goal is less than 1%, not less than 4%. So there are some standards that can guide us also. So here's an interesting one. And let me tell you, do I ever see this in clinic? If there's a discrepancy between laboratory A1C and CGM A1C, which one do you follow?
I my personal peeve, and those who work with me know this, I don't like the A1C because, again, I think it's an average that overlooks reality sometimes, especially, again, for our patients with high variability, because we don't care about the average. We care about how patients are actually doing. And to me, it's their actual blood glucose levels. So I look at the time and range and I look at that AGP. I don't usually look at the GMI, the glucose management indicator, which is like the calculated version of A1C. You know, for the lady that I showed you, I was just looking at her report. Her GMI was 6.9. Same time her A1C was measured, it was 8.2. And that's because she is neither flat, narrow, or in range, and that's why. So we really care about having their blood sugars in a safe range, at least for me.
I feel like I probably focus a little bit on both, looking at that time in range. And I'll bring it back to the remote world, that GMI, because some patients haven't been able to come in for their labs. So having that information at least gives a little bit of a guide in terms of where they may or may not be, where they may or may not be, be going, and explaining to the patient this isn't an exact GMI, it's an estimation that, when you go to the lab, it may not always be the same. Because I think for a while when we were talking about that GMI and patients would have their labs and their A1C didn't come back exactly the same, they would somewhat get frustrated and be like, yeah, but the GMI said this and my A1C is this. So just again, having that conversation of this is what this means. This is what it's not going to be exact, but again, it's giving you a little bit of that guidance in terms of, hey, you're 8.2. We know that you want to be 7 or less. What do we need to look at? What do we need to focus on to make those changes to get that, not only to get really that time and range up.
Yeah, and we have to realize, right, A1C is not perfect, right? It's affected by red blood cell turnover, by various anemias, by illness, by chronic kidney disease. Even there's variability by just hemoglobinopathies and different racial and ethnic groups. So it's not a perfect measure. It's a surrogate. It used to be the best we had, but I think now we just have better.
Well, and it's certainly more timely. It's a surrogate. It's also very time limited. It's a 3-month average. And you're right, impacted by all sorts of things. Whereas the time and range is something that's much less time averaged and much more actionable in the short term. And so it really, maybe that's the tool that we use to improve our A1C measures. Here in Minnesota, Dr. McCoy and myself are measured by our A1C measures, and it's publicly reported. So in primary care, it gets a lot of attention, but I think time and range may be a much better tool, especially for folks on insulin, to help get us where we need to be. Okay, so here's a question for Stacy. Really like the successful patient caregive use. Those are great chunks of information. How long does it take you to do the 6 steps you outlined on average?
So a typical training where you're kind of going over the insertion of the sensor, setting the target goals, is usually about 60 minutes. That's how we usually book or schedule those patients. For the older adult over the age of 65, that appointment might be slightly longer at 90 minutes. And then we usually try to have a follow-up 2 to 4 weeks after they start CGM. And in part of that follow-up, it's going through, how are you doing with everything? What's your response? And then taking that deeper dive into the reports.
Perfect. Okay, so here's a technological question regarding specifically intermittently scanned sensors. How frequently do you need to scan intermittently scanned sensors to capture all the data? How long can those sensors hold on to their data?
8 hours, right, Stacy? I'm not crazy. Okay.
8 hours
yep.
It is.
Yep, you're not crazy. 8 hours.
if you go beyond 8 hours, what you lose is the data that's at the front end of your data set. So if you sleep for 10 hours because it's the weekend, you lost 2 hours at midnight or something like that.
Mhm.
I know what I tell my people is go ahead and scan as often as possible, before meals, after meals. You get real-time data. You can see the trend arrows, whether your glucose is going up or going down. And in addition to that, you're transferring data from the sensor to the reader or telephone. So you're saving all that data for retrospective use.
Yeah, if I can jump on that arrow thing, I think that is incredibly powerful and helpful because I think, for many of my patients, especially if you can imagine a situation at bedtime, they measure their blood sugar and it's 100. It really matters whether it's a flat 100 going up, or rapidly going down 100. And I think it really prevents a lot of that overreaction and overtreatment that can spiral into that cycle of lows and highs in the roller coaster if we know what that point in time is actually doing and where it's going. Also encourages our patients to test more frequently, potentially, if the arrow is pointing up or down, and know when to test. But I think it really context, our bodies aren't a static thing. We are changing. So I think having that directionality and that arrow is incredibly helpful, and a great safety tool too.
I would add to that, yes, having, as we think about the arrows, I feel like that comes further down the education road. I feel like patients need to get used to just the overall use of it, and then you get into a further discussion about the arrows. And I often give the example of it, to your point about safety. If you saw 2 arrows going down and you were about to go drive, you might not want to get in your car. You're going to want to confirm that glucose with a finger stick and treat so that you're not driving.
Perfect. Yeah, trend arrows, very useful for sure. So I have 2 questions about correction dosing. So maybe we can send this one Stacy's way. What do you say to patients who check their finger stick blood glucose and intermittent scan CGMs before injection correction dosing? What reading do you recommend? Some of my patients just don't want to trust the CGM data.
Yeah, and for a patient like that, I think it's really okay. It's really okay to say, we were always kind of taught that the finger stick leads as opposed to the CGM. And certainly then there's always that conversation of if how you feel doesn't match a finger stick reading, you're checking. But if there's a certain level of comfort and the patient wants to do a finger stick, by all means. And you have to also remember that some of the devices are not FDA approved to make insulin adjustments off of the data. So patients have to be, you as the provider have to be mindful of that.
And I think the one thing that helps, especially for early on when my patients may not trust the CGM because of that discrepancy, it helps to preempt it by explaining that we do expect the numbers to be different because they are measuring a different glucose level. It's a different compartment. So not only is there lag time as the glucose equilibrates into the interstitial space, it's a different glucose. And if you go through like the cycle of blood from the heart to your organs and then back to the lungs, and they're giving up oxygen, and where you expect there to be less oxygen and less glucose. So when you go through and you kind of say you expect it to be low, and you said that like different, and the fact that every FDA approved device is going to have intrinsic variability, and it's still fine. You can poke 2 fingers and they can vary 20 milligrams per deciliter, and that's fine. And so I think setting that expectation up front prevents our patients from losing trust in a new device because they expect it to be different. And in reality, because of that variability, you tell them the truth is somewhere in between. How you feel is important, except if you're unaware of your hypoglycemia, and then you go with whatever is the safest for you. But again, it's setting that expectation so people don't lose trust is important, I think.
Perfect. Love it. So last question, we're running out of time. A recent publication has highlighted the differences between GMI, glucose management indicator, and A1C. How do you explain this in your patients where the GMI based on the glycemic metrics says one thing, the A1C sometimes is considerably different?
think for me, it's similar to what we already mentioned. I tell them I don't like the A1C, but you kind of go through that the A1C is affected by other things. It's a lag time. This one calculates 14 days. The A1C is 3 months or different depending on your red blood cells. So I think more explaining of what it means rather than to my patients, I don't necessarily discount the A1C, but we just kind of talk through about what they are, what they're measuring, and what each piece of information tells us, and what it means, and why do we care? I mean, and that's meaning the association with clinical outcomes like complications.
I would say that I generally describe it the same way, and I always kind of also say that, at least for right now, the A1C hasn't gone away. Could that be what the future is going to bring us? It's probably up for discussion and at a much higher level. But just trying to, I think, focus on the time and range, but then also, the focus on the A1C, because that's still a metric that we use.
Right. And there's a time and place for everything. I think the A1C is useful and reliable in patients in whom you do not expect a lot of variability. So patients who are not treated with insulin, or even patients on a sulfonylureas, they could have lows, but usually the A1C is more reliable. I think it's really patients on intensive insulin therapy with a lot of variability in whom I don't rely on the A1C. For other patients without great variability, I think it is still a useful tool.
Perfect.